Hi, greetings from ERA Lucknow Medical College and Hospital. I, G.K. Singh, will talk about micturition and its abnormalities. First of all, you see this pelvis, medial view of pelvis. This is the pubic symphysis. This is the pubic symphysis. Then you draw the medial border of the pelvis, the auricular process where the sacrum articulates, the greater sciatic notch, the ischial spine, the lesser sciatic notch, the ischial tuberosity, the ischiopubic ramus, and coming back to the pubis. This is what is the true pelvis, and the pubic crest here, the pubic tubercle, the notch for the artery, vein, and nerve, the pectineal eminence, the anteophiliac spine, the anterophiliac spine, and the iliac crest. This forms the false pelvis. Now there's a ligament which is the sacrotuberous ligament, this one, sacrum to ischial tuberosity, and sacrospinous ligament, this one, the internal part of which is the coccygeus muscle, the outer part is the ligament. This makes these notches into foramen, the greater sciatic and the lesser sciatic foramen. And there's a tendon which runs from the ischial tuberosity to the pubic symphysis. This is the tendon of the levator ani. And the levator ani arises from this tendon, this levator ani, and goes on to the coccyx. So, this levator ani is actually like a diaphragm. It's like a diaphragm, like this. And it basically divides the true pelvis into an upper pelvic portion and a lower perineal portion. So, on this side is the pelvis, and this side is the perineum. So, this is the pelvis, which is a basin shaped cavity, and I have told you how the levator ani divides it into a pelvic portion and a perineal portion. So the levator ani is also called as the pelvic diaphragm, and it gives passage to the urine, to the baby, and to the feces. So the urogenital triangle directed forwards passes the urethra and the vagina, and the ischiorectal anal triangle gives you the passage to the anal canal. So on this we'll place the bladder. So basically what you have to realize is that the ischiopubic ramus, you have this perineal membrane, and there is a superior fascia of this on this perineal membrane forming the deep perineal pouch, and superficial to the perineal membrane you have another fascia which forms the superficial perineal pouch. The superficial fascia goes on to form the fascia of the penis, and then goes on to form the scarpa's fascia in the abdomen. So you have this deep perineal pouch and superficial perineal pouch, which you will find are pierced by the urethra. So here is the bladder, and this bladder ends into part which is enclosed by this prostate gland, and this becomes thus the prostatic urethra. Then it pierces the deep perineal pouch, and this is called as the membranous urethra, and it ends into a perineal urethra which initially goes up in the perineum and then into the penis. So the perineal and the penile urethra. So the bladder The prostatic urethra, the membranous urethra, the perineal urethra, and the penile urethra are parts which are responsible for retaining the urine and then emptying it where appropriate. The bladder is filled by the urine by what are the ureters, and the vas deferens, comes from the anti-abdominal wall, this red one. It crosses the ureter, then turns down, goes behind the ureter, and ends in the ejaculatory duct. So this ejaculatory duct, which opens in the prostatic urethra here, is an ejaculatory duct formed by the vas deferens and the seminal vesicles which store the sperms. So this is the ejaculatory duct, and this is the vas deferens, and here is your vas deferens coming. So this prostatic urethra provides sperms also which go through the penis. So it also provides for the reproduction in the male. Now we look at the section of this bladder. This bladder consists of a muscle, and this muscle is basically crisscross. And blood vessels pass through this muscle. So what happens that when this muscle gets distended, these arteries get compressed. Arteries do not get compressed, and they keep on supplying the blood to the mucosa. But the veins which drain, the veins are lying between the fascia transversalis and the muscle. Here in this space, these veins get compressed. Therefore, the mucosa initially becomes congested and then can bleed, leading to hematuria. So the arteries crossing the muscle and supplying the mucosa, and veins remaining outside the muscle, is responsible for hematuria in an over-distended bladder. So hematuria in an over-distended bladder. Okay. The second thing is that these fibers are crisscross. So normally a muscle will undergo phases of contraction where the length reduces and relaxation where the length is restored. But here what happens that the muscle contracts, relaxes, but because of this crisscross nature, they get entangled. So the original length is not restored, and this is called as retraction. So a bladder muscle is special in the way that it contracts, relaxes, and retracts. Same is the feature of the uterine muscle too, but this character allows the bladder volume to be retained even when the muscle is relaxing. So repeated contraction relaxation will continue to keep on decreasing the volume of the bladder by this phenomenon of retraction. Now we come to the innermost layer, which is the mucosa. The mucosa is smooth in a triangular portion which is called as the trigone. And this trigone on these sides are the ureteric orifices, and in this, on the lower side, it ends in the median eminence, which is produced by the prostate gland. When the prostate is enlarged, this median eminence can sort of go like this and shut the urine flow through the urethra. So this is called as the trap mechanism of the median eminence, because here is the prostate. If this is enlarged and person is trying to evacuate, this will just slide down from this position to this position and shut up the urethra. So patient, as he strains, the urine flow goes down. So this is about the importance of this median eminence. Then you have the prostate. These are the internal sphincters. These are the internal sphincters. They are before the prostate, and when the local activity of these muscles, bladder muscle, increases because of distension, because of stretch, internal sphincter relaxes and allows some urine to pass into the prostatic urethra, where you have an eminence which is called as the verumontanum, On this verumontanum are the ejaculatory ducts. Like this, and this H-like structure or slit in the verumontanum is called as the utriculus masculinus, the uterus of the male. So this is the ejaculatory duct on the verumontanum. Then this much part of the bladder up to the internal sphincter is in the pelvis. So this is the levator ani muscle. Then you have the prostate, the prostatic urethra, and then you pierce the deep perineal pouch. Here you have the membranous urethra. Then you pierce the perineal membrane, and this becomes the perineal urethra. So if you look at it from the side, you will see the perineal membrane, the deep perineal pouch, the superficial perineal pouch, including the testes, going into the penis also. So here is where the prostate is. Here is the bladder on this side. This becomes the membranous urethra. It is surrounded by a muscle which is called as the external sphincter, supplied by this pudendal nerve which lies in a canal which is called, canal is here, which is called as the Alcock's canal. So then it becomes the perineal urethra. After the membranous, it becomes the perineal urethra going up, and then the penile urethra going down, and it is held to the pubic symphysis by the dorsal ligament of penis, and the vein draining the penis passes this dorsal ligament and goes into the bladder. So when there is over distension, the venous plexus around the bladder, between it and the fascia transversalis, is blocked, and this leads to the dorsal vein of penis not draining. Therefore the penis would become congested with blood, and there will be a painful erection of the penis, which is called as priapism. So this is the applied anatomy of this bladder and how it functions. Here is the levator ani muscle. This is the obturator internus. Then in the false pelvis, you have the femoral vein, artery, and nerve. Then you have the psoas, the iliacus, and the three muscles which suspend this pelvis, which is internal oblique, transversus abdominis, internal oblique, and external oblique. So this I have identified all important structures which are around the bladder by these three diagrams. Now we'll study the normal micturition. The normal micturition is the bladder fills 400 cc. As soon as the bladder fills 400 cc, there is a stretch reflex. And this stretch reflex increases the activity of the bladder muscles. And it relaxes the internal sphincter. But the urine would not go back into the ureter because the ureters have crossed the muscle obliquely. And as the bladder muscle contracts, the ends of the ureter are obliterated. So there is no vesico-ureteric reflex normally. But if the lower end of the ureter gets fibrosed, as in tuberculosis, then this is called as the golf hole ureter, and it will permit a vesico-ureteric reflux. Then, because of the local stretch reflex, there are uncoordinated contraction of the bladder, of the urinary bladder. The second effect is that the internal sphincter is relaxed, and therefore the urine trickles into the prostatic urethra. The chemoreceptors in the verum montanum are activated. Impulse goes to the spinal cord. The spinal cord informs the cortex and initiates a coordinated contraction of the bladder from the ureteric orifices, because the ureteric orifices become the pacemakers of the bladder. But you can't micturate everywhere, so the external sphincter supplied by the pudendal nerve from the Alcock's canal keeps contracting and preventing a leak before the time of micturation arises. So then the place is found where you can evacuate. This place is found where you can really evacuate. You have reached the bathroom, and the external sphincter relaxes. The urine flows out in a stream, and the flow is sustained till the urine is passing over the chemoreceptors in the verum montanum. Therefore, the evacuation is almost always complete. 400 cc of volume is reduced to less than 50 cc, and this 50 cc is called as the post-void residual urine, and we will call it PVR henceforth. Now, excess PVR indicates incomplete evacuation, which can cause stasis, stone, and infection. Now we'll talk of the neurogenic bladder. So first, in the neurogenic bladder, allow me to tell you about the oscillatory circuits in the neuron. Oscillatory circuits are circular. They come back where they started. So they are like a circle. So if neuron A stimulates B, then C, then D, then E, and F come back to neuron A, and if by this time the neuron A is not in the latent period, then the impulse will start going round and round. And at a fixed point, you will have an electrical impulse. At a fixed point, you will have an electrical impulse at a fixed frequency. So this oscillatory circuits are found in a reticular activating system, which is in the midbrain, in the pons, in the medulla oblongata. From the reticular activating system, there are ascending fibers which can go to the cortex. More the activity, you are awake, and less the activity, you sleep. Then through the thalamicocortical beam, through the thalamus, they can activate local areas of the cortex where the memory which is stored in them can become alive. So thalamicocortical fibers are responsible for memory. Then there are the descending fibers from the reticular activating system, which end in the internuncial neuron system, which is in the part of reticular activating system in the spinal cord is called as the internuncial neuron system. Now this internuncial neuron system supplies the bladder. And now with 400 cc's of urine in the bladder here, the bladder muscle activity will start, and what we are saying is that then urine will come into the prostatic urethra, and from here the spinal reflex will start. The spinal reflex and the efferent fibers will start making the bladder contract in a similar manner. But supposing there is a spinal section, so everything below the reticular activating system stops. There is no electrical activity in the bladder. This is called as neurogenic retention. Now the bladder will keep on over distending. The veins will get compressed between fascia transversalis and the muscles, and they cannot now drain. The arteries which are crossing the muscle will keep supplying the mucosa, and as that continues, mucosa will get congested and will bleed and will lead to hematuria. Therefore, at the earliest possible moment in the pre-hospital care, you should be able to detect the over-distended bladder and put a Foley's catheter to provide this hematuria, to provide over-distension. Now, this hematuria can lead to infection because it's a good culture medium, and this can lead to cystitis. Now, the local reflex of the bladder becomes effective so that in over-distension, some urine dribbles. It will not empty completely because as soon as some urine dribbles, over-distension will disappear and the dribbling will stop. So the emptying is not complete. The post-void residual is higher than greater 100 cc's, and this type of bladder is called as autonomous bladder. Then the spinal reflex returns. The bladder empties in a stream because now the spinal reflex is causing coordinated contractions. The post-void residual is less than 100 cc as now the chemoreceptors are active till the urine is flowing across them. Such a bladder is called as automatic bladder because neither the cortex is informed nor can it do anything to stop micturition. Then sensations of bladder full return. They start reaching the cortex. So he is able to tell that he is about to pass urine and you should give him a urine pot. This is called as a sensate bladder. Then he can partially hold the bladder, that's called partial control. So that is two type of things. When he tries to micturate, he cannot start easily. That is called as hesitancy. Or he can't hold it properly. That is called as precipitancy. These are the features of partial control. Then, of course, the last stage is normalization of bladder. In the pre-hospital, you must detect retention and you must treat by continuous catheterization of Foley's catheter, because this will prevent over-distension and hematuria. In hospital, you can keep on clamping and releasing the Foley's catheter. Don't keep it either clamped nor keep it open, because this allows the bladder to keep on distending. So if you release, how frequently should you release? You take the 24-hour volume of urine and divide by 400 cc. Supposing the urine 24-hour output is 1200 cc, divide by 400, it comes to be 3. So 3 times you would unclamp or release the urine. So you do this because you want the bladder to keep distending and contracting and distending to 400 cc's. So after this, remove the Foley's catheter, because if you keep the Foley's catheter on, the glands which drain in the urethra will keep blocked. There will be a periurethral abscess, there will be a urethral fistula, and you will end in a water can perineum. So as soon as possible, remove the Foley's catheter. And then what you do, first of all, you put suprapubic pressure. This is called as emptying by Creed's method. So as you put suprapubic pressure, urine will flow out. So after evacuating the bladder by Creed's method, then you do an intermittent catheterization by a simple catheter, sterilized catheter, and you measure what is the post-word residual. When the post-word residual is under 100 cc, you use only the Creed's method to empty bladder. But here you should be very careful. You should watch for infection by weekly culture. You should prevent it by plenty of fluids, plenty of water, which induces diuresis. Bladder wash can compensate this diuresis. Change the pH by giving alkazol so that bacteria like E. coli don't grow in it. And you can give antibiotics as per culture sensitivity. What are the complications which have to be prevented, which have to be detected and managed? The first is infection. Infection in urethra, periurethral abscess, fistula, water can perineum. Thus, intermittent catheter is better than continuous catheter, and continuous catheter must be replaced as soon as possible by intermittent catheter. Then it reaches the prostate, prostatitis, vas deferens, funiculitis, epididymis and testes, epididymoorchitis. Higher up, bladder, cystitis, then pyelonephritis and renal failure. Then you have hematuria, stone, and if you keep the bladder on continuous catheterization, then and you do not clamp it, bladder will become contracted. This is called as the thimble bladder, and later on you will have to use ileum to restore the volume of bladder. The operation is called as ileocystoplasty. Thank you for a patient listening.